2, 1.
Thank you, everyone. My name is Jack Tan from Singapore, and on behalf of the Singapore Cardiac Society, I would like to thank Professor Jiang Jun and QICC for conducting this joint SCS-QICC 2022 joint scientific session. I'll hand over the time to the session chair, Dr. Chee Yang, to introduce the session. Thanks, Chee Yang.
Thank you, Jack. Thank you again to the QICC organizers for inviting us to participate today. So today we have a few very interesting talks on advanced PCI techniques. And I think without wasting any time, let's go to the first talk, which will be presented by my good friend and colleague, Dr. Pham, please.
Thank you, Dr. Chin. I'm just wondering whether you all can see my slides.
Yes.
Okay, good afternoon, everyone, and many thanks for the kind introduction. Left main disease remains one of the most challenging lesion subsets, with generally a lower procedural success rate and increased rates of long-term adverse cardiac events. In the next few minutes or so, I'll be covering my approach to left main disease, some tips and tricks for procedural success. Now, with regards to the anatomy of the left main, two main features are actually emphasized here. There's distal bifurcation involvement in 80% of the time. And the implications of that is that frequently one need to consider bifurcation stenting, especially if there's significant disease in the osteocirc. Now, the median diameter of the left main range from 3.5 to 4.75 millimeters. So it's less likely for the left main to be anything less than 3 millimeters. The law of finesse depicts the relationship between the diameter of the left main and the daughter vessels being the LAD and the circumflex. Ideally, the left main diameter should be 2/3 the sum of the LAD and circumflex. Now, there are several ways to classify bifurcations, two of which are shown here. The Mendelian classification is an earlier type that's used, depending on whether there's disease in the proximal main, distal main, or Sept branch. It does not, however, take into account bifurcation angle, calcification, or lesion length. That can be important to be considered for any strategy of bifurcation stenting. The definition criteria, as shown on this right-hand panel, considers bifurcation complex if it has one major criteria or two minor criteria. I just want to highlight for the left main bifurcation, it's considered complex if it meets one major risk factor, that is the side branch diameter stenosis, 70% or greater, and a lesion length that's greater than 10 millimeters, or the presence of any two minor risk factors that is listed here. Now, the analytical features of the left main pose some technical considerations in the left main PCI, some of which are listed here. Sometimes there's a mismatch between the proximal main vessel and the distal side branch vessel size. So after you stand the stand according to the distal vessel, one is required to perform proximal optimization technique, or POT for short. The osteal lesion of the main vessel requires the use of a stent with high radial strength and calcification, and frequently encountered requiring more aggressive lesion preparation. Because the side branch tend to supply a larger territory, the risk of hemodynamic compromise is higher from plug sheath dissection, requiring broad stenting of the side branch. Generally, in order to overcome these technical challenges, optimal PCI is necessary to improve clinical events. This includes the use of coronary imaging, such as IVUS, appropriate bifurcation technique, and the appropriate choice of DES. I'm going to share with you all some tips and tricks listed here that one may apply in left main stenting. Now, the first tip of following the general rules should be applied to most intervention techniques. Though this may sound very fundamental, one can never take for granted the importance of a careful review of anatomy, selection of one or two optimal optical projections to guide a procedure. Now, use of appropriate views can assess if the adequate stent expansion has occurred or dissection may have occurred proximal or distal to the stent. Good backup support is essential. Consider the use of femoral access for better support, and if one is to consider upfront bifurcation stenting, a larger guide size, such as a 7 French, may be used, and you find it easier to accommodate more equipment such as wires, bigger size balloons. Care, though, needs to be taken to avoid oversized guides and intubate the left main excessively and cause left main dissection. Now, choice of technique. Generally speaking, the one stent technique is preferred still whenever possible. The European guidelines recommend stent implantation in main vessel only, followed by provisional balloon angioplasty with or without stenting of the side branch. Exceptions are when if there's a side branch with a long osteal lesion, for example, if one anticipates difficulty in assessing an important side branch after main branch stenting, or in the setting of true distal left main bifurcations. Some examples are actually shown here. This slide shows the algorithm of how left main bifurcation may be treated. If the side branch is less diseased, such as less than 70%, or relatively short, less than 10 millimeters, and relatively easy to access, consider the use of provisional stenting as first choice. Now, if the side branch access is deemed difficult, consider stenting the side branch first in an inverted keloid technique. And if there is evidence of side branch compromise, consider two-stent technique as well, and such as beyond side branch stenting, such as T, stenting, tap, or keloid. Now, if the bifurcation is clearly complex, as we mentioned earlier on, consider the upfront technique, regardless of whichever technique is used, consider the use of intracoronary imaging, such as IVUS or OCT. Provisional stenting with a single stent technique consists of stenting the main branch mainly with the diameter selected according to the diameter of the LAD. Now, if intervention is required to the ostium of the side branch, guide wire exchange is performed, preferably with distal recross with the main branch wire or a new wire. Kissing balloon is then carried out with two short, preferably non-compliant balloons, with the side branch balloon minimally extending beyond the ostium, and report is then performed with final result. Now, key steps of the three most commonly used contemporary two-stent techniques, such as the TK crush, keloid, and tap, are concisely demonstrated here. Now, regardless of whatever stents two-stent technique are required, this should be finalized with a kissing balloon inflation and repeat port to optimize the stent expansion and preserve bifurcation anatomy. Now, do note in crush stenting, rewiring the side branch from the proximal stent cell is favorable. This is in contrast to distal side branch recrossing, which may result in wire crossing the abluminal area between the stent and vessel wall, leaving a significant gap at the side branch ostium after final kissing balloon. The left-hand panel shows the vessel wall and ostium fully covered by the stent. The right panel shows the vessel wall and the ostium that's not covered by the struts. Now, the importance of ports. Achieving adequate ports is key to improve clinical outcomes, both by increasing stent expansion as well as to reduce malapposition. Many also can be used to minimize complications by preventing guide wire tracking behind the stent during recross. And in this diagram shown here, the best expansion phantom model was actually obtained with the use of port using non-compliance oversized balloons at high pressures, resulting in least malposition and most symmetrical expansion. Now, where the port balloon should be placed, ideally, the stent should have enough length and implanted sufficiently proximal to the side branch to accommodate the balloon at least 6 to 8 millimeters in length, and this balloon should be sized to the proximal main vessel. The distal marker of this balloon should be positioned in front of the carina and not extend distal to the carina. Doing so may overstretch the distal main vessel, causing dissection and plug shift. Now, another tip is to consider the use of imaging. It's relatively easy to perform, provides critical information in procedural planning, stent deployment, and post-procedural evaluation. Now, with imaging, operators can obtain precise vessel wall measurements, understand the underlying plug composition, features that may not really be seen on plain angiography. Ideally, pullback should be obtained from both the LAD and circumflex to obtain complete information on the bifurcation and avoid overestimation of the MLE of the circumflex ostium due to a non-coaxial orientation of the catheter from just a pure LAD pullback. Now, the information obtained can be used to further optimize or identify the optimal landing zones, facilitate matching between diesel eyes and vessel size, and avoid situations such as geographic miss. Now, an example of IVUS pullback is shown here. IVUS derived minimal lumen area, as seen in the central panel, allow operators to objectively determine if a lesion and left main bifurcation, for example, is significant or not. We can also use IVUS to avoid troublemakers such as a calcified plug, as seen in this right-hand panel. This will help us decide where to deploy the stent and determine the stent length and diameter. Sometimes difficult to size the vessel such as the left main accurately based on an angiographic assessment due to a lack of proximal reference segment. So in this case, the imaging can help overcome this limitation, and consequences of stent diameters used as too small include the fact that it may result in stent malposition or under expansion, or result in wire passage outside the stent and predispose to stent distortion. Now, intracoronary imaging also useful in stenting, bifurcation stenting, when confirming wire position other than using the traditional methods, as shown here. This image shows a spiky carina, or that of an eyebrow sign, seen on the IVUS automated pullback that predicts carina shift if a single stenting strategy is used. IVUS can therefore detect anatomic features which can favor double stent over single stent strategy. Now, this image on the left shows stent malposition. Post-procedural IVUS is also highly recommended to detect stent-related complications which not be really apparent on plain angiography. Operators can then decide the further optimized result by performing post-dilatation with larger non-compliant balloons at higher pressures. The IVUS can also help us determine if adequate stent expansion has been achieved using specific target areas, such as 5 mm square for the circumflex and 8 mm square for the distal left main, for example. Now, the choice of DES is also important. The expansion capability actually determines the ability to oppose the device in a larger proximal main vessel and influence the choice of the stent as well. It's important to have open cell struts in order to allow full opening of the struts towards both branches. Thus, a stent with open cell design within struts also facilitates guide wire access, reduce the risk of vessel compromise, and recrossability. Shown here are some examples of stents with good expansion profile suitable for the left main or bifurcation stenting. A useful tip is to know the stent size and dimensions it can be expanded to, so it can be good to have a chart or table as an example for reference. Now, another useful tip to know is how to handle certain tricky situations. One example that's commonly encountered in left main stenting is difficulty access to side branch or the main branch, which can occur either at the start of the procedure or after the side branch or the main branch stenting. Some ways to overcome this difficulty include either reshaping the wire tip with a wide smooth band or using a proximal pullback wiring technique. Microcatheters such as the angled supercross catheter as seen in the center diagram may be used in conjunction with guide wires to access side branches. Even after access to the side branch or the main branch is secured, there may be difficulty advancing a balloon stent through the struts. Causes include unexpanded stent struts, stent deformation, or the wire could have crossed under the stent struts. Countermeasures include to repeat post-dilatation to correct any proximal stent deformation, or to confirm wire position using imaging necessary, or to retry the wire crossing with the help of a microcatheter. Now, a gel balloon technique was first published in 2012 as a way to prevent gelling of the side branch. A monorail balloon that's sized to the side branch vessel diameter, generally 1.5 to 2 millimeters, advanced to the side branch, and the proximal marker was classically positioned just 2 mm proximal to the stent to prevent entrapment, and with adequate balloon length to project into the side branch ostium. We have a modified gel balloon technique that was described by Dr. Saito in 2017, which involves placing a small profile gel balloon in the side branch but not protruding to the main branch, and inflation of this side branch balloon to nominal pressure, typically up to 12 atmospheres, and followed up by a pot performed to correct the stent, any stent malposition with a short non-compliant balloon. I just got 2 case examples to show. The first example is that of a tight left main bifurcation with TME2 flow down the LAD. And we elected to do a pre-dilatation of both vessels with a 2O balloon. IVUS pullback showed the very tight LAD lesion with a diseased circumflex as well, so suggesting that we should actually consider an upfront bifurcation strategy. And the important thing is to cover the bifurcation at least 6 to 8 millimeters here from the proximal stent to the carina to enable subsequent ports with a short balloon. Now, in this case, because of the complex bifurcation, we elected to do a double stent strategy using a double kiss crush technique. DES is actually deployed first from the circumflex to the OM, and it's deployed actually with minimal protrusion in the left main. And I use a non-compliant trio balloon from the left main to the LAD as a marker. The side branch stent is post-dilated before I crushed it. And then subsequently, the circumflex is recrossed. And next, I work on the LAD. And here I illustrate some of the criteria for on the IVUS that I've used to determine the optimal landing zone, such as a large rumen, smallest plug burden, and no troublemakers. final angiogram showing reasonable angiographic results and IVUS showing that the stent is reasonably well expanded. Next example is that of a Mandina 101 bifurcation as well. Pre-dilation with a semi-compliant 25 mm balloon and Scoreflex trio. Using IVUS again, I managed to size the daughter vessels and the left main and landing zone criteria. In this case, I elected to use a keloid technique. For the left main to the stent, I used a trio 15 DES. Did a first pot. This is to prevent my wire from inadvertently crossing under the stent struts during recrossing. And after a first rewiring, I elected to open the side branch. Okay, excuse me, there's a hang in the slides. Just give me a moment, excuse me.
No problem, no problem. So while we wait for Dr. Pham to reload his slides, maybe we can have a bit of a, oh look, okay, maybe it's coming up. Okay,
Are you all able
I
to
think
see the slides further? Yeah,
yeah,
me,
we
sorry.
can. Okay, why don't you continue then?
Yeah. Okay, so this is the first rewiring with the side branch opening. And then we stented the left main to the LED with a trio 28 millimeters. And a pot, first pot with a non-compliant 3.25 mm balloon. And then we did a second rewiring of the circumflex and a final kissing balloon inflation with a 3.25 mm balloons and an NC trio mm balloons in both side branch. And we end with the final pot with a 4 NC balloon. And just the final IVUS images and the images results as well. So in summary, advances have made it possible for PCI to be a reasonable revascularization strategy in selected left main lesions. The upfront two-stent strategy for complex bifurcation lesions may be beneficial. DES imaging and right optimal technique form the three main strategies of achieving optimal outcomes in bifurcation PCI. And knowing the tips and tricks is essential for procedural success. And thank you very much for your time.
Okay, thank you very much, Dr. Pham, for that. Good summary of all the considerations that need to be at the back of our minds when we do left main PCI. So, Jian Ming, let me ask you a question in general. So, for your whenever you intervene on the left main, is imaging a must for you? Is it a must-have or is it just a good-to-have kind of tool?
Well, I think it's a good question, Chiang. I do believe that the use of intracoronary imaging is actually critical in most cases, especially in regards to the left main stenting. It provides really important information in regards to pre-procedural sizing, especially when in quite a few cases there may be no suitable proximal reference diameter to select. And as I illustrate with regards to the specific anatomy of the left main, quite frequently bifurcation stenting may be required. You may actually have to do a pot with a large oversized balloon. So it's actually pretty important, actually IVUS can or OCT can actually guide us to the appropriate size of the balloon that's required without causing injury.
Yep, I probably would agree with that. I think if you have imaging available in your lab, then there is very little reason not to use it. Yeah, of course, some labs may not have imaging available, so then there's no choice. But if imaging is available, I think, left main is the one lesion that you really want to get right. Yeah. Jieli, can I ask you a question if you don't mind? So Jian Ming, mentioned about the utility of imaging. What do you think about the utility of physiology in assessing left main?
I guess physiology for me is probably more of to assess significance of lesions. And imaging really is more to optimize it. So I think it's two quite different modalities. So I might use physiology to assess whether a left main lesion needs to be intervened. But if I'm going to touch it, then I think more than 90% of the time I'll probably use imaging. Maybe just in an acute setting, like for example, STEMI, sometimes certain situations where I might not pull out my imaging. But other than that, actually most of the bifurc left main cases are elective settings. And I think imaging is actually probably something that's quite important.
I have a question to Jieli as well. Is it okay?
Mm-hmm.
Yeah. Normally, when you do a provisional stenting and your side branch got pinched somewhat, do you routinely put a pressure wire down to assess the flow physiology before you?
Yeah, so I think there are some studies that look at that to say that may help you decide, but personally I don't do that. I mean, they are not big studies. I do still just go by the general rule of thumb, whether there's good flow, how big is the side branch, whether patient has symptoms before I decide. I have to say that my threshold for doing bifurc PCI is actually quite high, because I do believe that when you put two metals in the left main, it probably increases the long-term cardiovascular outcome. So I myself, I do have a very high threshold for that. So yeah, so I don't use physiology to assess the side branch.
Our colleagues from China, Dr. Liu, Dr. Zhang, do you have any comments or questions for the presenter?
Thank you. So I'm totally agree with use imaging choice to guiding PCI procedure for the left main, especially for the bifurcation lesion. So I have a question for the speaker. So compare with IVUS and OCT, what's your choice in this situation? And also I will ask a question about after the stent crossover circumflex, what's the role of FFR to identify ischemia for the circumflex? Thank you.
Thank you for your question. Now, in general, there are basically two main forms of intracoronary imaging modalities that's available, right? Be it IVUS or OCT. So I think that both have their own advantages or disadvantages. The IVUS advantages would include that we do not need any form of contrast clearance. So that's relevant in a patient that may have a pre-existing chronic renal impairment. IVUS has a long history of usage and widely available evidence backing its use, such as the IVUS XPL trial or ultimate trial as well. More readily available, and I dare say greater tissue penetration, except in the case of calcium. Now, its disadvantages include that there is lower resolution, slower pullback speed, and cannot penetrate calcium as well. Now, in regards to OCT, yes, the advantages include that it's much higher resolution, can potentially identify the wire position better, which is relevant, especially in terms of the bifurcation stenting. It can assess calcium better and stent apposition better as well due to its higher resolution, faster pullback speed, so you can, assess the same segment in a shorter time. The disadvantages of OCT will include the fact that it needs contrast clearance and less tissue penetration, less widely available. It's generally more expensive. Yeah. So that's my inputs to your question. Now, in regards to circumflex, whether I would stent circumflex, I guess your question is if we do provisional stenting, when will we end up doing bailout stenting, for example, using, for example, a tap technique? Generally speaking, my slides did show that if, for example, the flow is TME2 or less, or if the FFR if you put an FR and it shows a reference value of 0.80 or less, then one may consider a bailout stenting to the circumflex.
Okay, thanks for that response, Jiang Ming. I'll just add on very short point about the use of OCT in the left main. Sometimes we are told that, you know, OCT may not be so suitable for use in left main because we need to engage the left main properly for contrast clearance, and sometimes that means that we might miss very proximal or an ostial left main lesion. There are ways to overcome that, and one of the ways to overcome that is to use a guide extension catheter. And most guide extension catheters, the distal 2 millimeters, actually allow OCT to penetrate through. So we can disengage the guide with the guide extension catheter sitting just 2 to 3 millimeters inside the left main, and that can still give us good contrast clearance and still allow us to assess the ostium of the left main. Okay, I think we should move on to the next talk. The next speaker is Dr. LEE Jin Hyun from Singapore, Tock Seng Hospital.
Yeah, just want to thank KUICC for inviting me to give this talk. So yeah, you can see my slides. So basically, my talk is on high-risk PCI and mechanical circulatory support. So it was given a name as CHIP for high-risk PCI cases, first in the white paper that was published in 2006 by Courtenay. And this describes it as complex, higher risk, and clinically indicated patients. So they define this CHIP population as not only patients with complex coronary anatomy, but also with significant medical comorbidities and adverse hemodynamics. So with the rising prevalence of complex coronary artery disease, with the increasing patient comorbidities, and correlated with coronary artery bypass surgery ineligibility, there's growing number of patients that require complex percutaneous treatment strategies. So there's been various definitions of CHIP, but it is basically a confluence of characteristics, including the complex coronary anatomy, the hemodynamic status, such as the severely impaired LV ejection fraction, and clinical comorbidities. So as you can see from the appropriateness guidelines for coronary revascularization, with increasing heart failure symptoms, with increasing angina and increasing anatomy complexity, it becomes more appropriate to revascularize these patients. And if you can see, even in the stable IHD guidelines, with more complex disease you have, there is lower 5-year survival, assuming the patients are only treated medically. So there is this population, subset of population where they're undertreated in high-risk cases. So really the best practices in complex revascularization is done in the context of heart team. And this heart team is as recommended by Class 1 in American and European guidelines. It involves basically a team of cardiac surgeon, the heart failure team, and the interventional cardiologist. So this is a study which looked, it was published in JAG and HA, and it looked at multidisciplinary heart team approach in MGH, basically a single center. And they re-stratified this heart team recommendation by SCS and syntax scores. And what it showed is that it's not the syntax score that drive patients. There was no correlation between OM, medical therapy, PCI, or bypass recommendation in terms of syntax score, but really it's really the STS score as it goes up from the low, intermediate, high operative risk. Basically, there were trends where patients going for bypass decreased and it was treated medically. So basically, these are the complex anatomy patients that are shunted to high-risk PCI as a function of other comorbidities. So this slide basically shows that it is very important to assess patient carefully, and these are the factors that ultimately results in increased mortality, such as CKD, impaired LV ejection fraction, valvular disease, incomplete revascularization. And all the more we should take every effort that we can to optimize this, especially severe calcification, which are difficult to treat patients. And they suffer from stent underexpansion. So judicious plaque modification with use of atherectomy and intravascular imaging is crucial. So based on the SCI expert consensus opinion regarding the PCI risk stratification pyramid, they integrated basically PCI complexity, clinical comorbidities, and the site where PCI is to be performed, and is really the group C patients that we are targeting. So with this outline of high-risk groups who are undertreated, so what is the role of mechanical circulatory support? So it is basically the aim is to improve safety and efficacy of PCI in patients who are at very high risk for revasc. And observational studies so far has demonstrated that there is improved procedural cardiovascular hemodynamics and more complete revascularization with MCS support. So this is the JACC paper that basically lay out the hemodynamics very well. So they illustrate a case of very tight distal left main with an RCA CTO. So it's basically a patient who has very little physiological reserve. And as you can see, there's aortic pressure and the LV intraventricular pressure. And during this transient left main balloon dilatation, this will cause a profound myocardial ischemia in this patient with so little reserve. So this causes patient's blood pressure to drop below his own mean arterial pressure, and the circulation is only maintained by the pump, which consistently provides 3.2 liter per minute output in this case. So this is what we call the ventricular arterial uncoupling during the case, and it goes back to normal. So how do we know which patients to use MCS and which not to? Basically, these are the this is the slide that I got from Dr. Jeffrey Moses from Columbia. I mean, he just gave some examples of which cases to or not to. First thing to think about is the patient hemodynamically unstable, low BP. Yes, then consider MCS. Does the patient have reserve to sustain brief ischemic insult? Just like the case that we illustrated on JACC just now? No, then consider MCS. Is the patient at risk for a complete interruption of a blood supply that will lead to hemodynamic collapse, such as difficulty wiring with risk of abrupt closure of a large vessel? Then yes, consider support. And lastly, is the patient at risk of prolonged ischemic insult, limiting my ability for complete revascularization of the patient, or or subject the ventricle to stunning? Especially in terms of addressing left dominant circulation with complex bifurcation, or when you're performing a retrograde CTO, which might cause dual circulation compromise, then you should consider support. This is one algorithm that was proposed by the McCabe from University of Washington. He looked at several factors that you might score to, if the score is 4 or more, then strongly consider support. So one of the interesting finding is that he used right heart cath readings, cardiac index less than 2, or PA sets less than 55. So basically, it just stressed the importance of knowing the baseline hemodynamics even before we consider support. And even during the case, serially monitoring the PA pressures and also using the right heart readings to decide on whether the patient can be weaned off the MCS on table. So this is the table showing optimal revascularization strategy. Basically, all the trials like the STITCH, the Excel Noble, BCIS1, basically have been addressing the low to medium risk. Basically, the high risk patients who are often inoperable is the group where we need to consider, should we use support or not? So there has been accumulation of evidence over time, especially the PROTECT series studies, which was started in 2006. And then PROTECT 2 was the randomized pivotal study that got the FDA approved for Impala in 2015. And then they moved on to PROTECT 3 and RESTORE EF, which showed and validated the best practices And now the ongoing trial is the PROTECT 4, which is the randomized trial, which is ongoing. So there has been data accumulation about the importance of complete revascularization. This shows the pool analysis of the Syntax pre-combat and BEST trials published in JAG, where it shows that incomplete revascularization with PCI is related to lower survival rate. This is also confirmed in this SCI statement, where complete revascularization is associated with improved outcomes in high-risk cases where there is risk reduction in MACE, MI, and cardiovascular death. It is also shown in the PROTECT 2 trial, where they compared the limited revasc group with the extensive revasc group, where the extensive revasc group has lower MACE compared to the limited one. And how MCS helps in this case is basically it maintains the hemodynamic during the procedure. As you can see, compared to the balloon pump, the Impella, there was much less procedural decrease in arterial pressure during the revasc. And in comparison with the PROTECT 2, PROTECT 3, there was introduction of Impella CP, and it was a group of patients which were much more complex. There was higher use of atherectomy, and clearly in this case, at 90 days, it showed much lower MACE compared to the PROTECT 2 group. And there was also fewer adverse events that was reported in the PROTECT 3, and it basically shows we're getting better in applying best practices and leading to better patient outcomes. So interventional procedure matters. We need to use the latest DES, IVUS, use of IVUS, use of all the atherectomy, calcium modification tools, and also we're getting better in terms of large bore access. This is the RESTORE EF study, which was recently published as well. It really shows in those who underwent elective high-risk PCI under Impella support, they studied the primary endpoint was EF improvement at 90 days. So what it showed is that there was a significant improvement in EF, especially those patients who had severely impaired LV ejection fraction to start with. And not only that, there was improvement in terms of secondary endpoint, which was the NYHA class and the CCS class angina. So how do we interpret this with the latest Revive Disease 2 study? The target population in this case was different compared to the studies that PROTECT series and all these high-risk studies that we have performed so far. The baseline characteristics in this study was reported as more than 65% had no angina, and 2% only had CCS class 3 angina, and more than 70% had NYHA 1 to 2. And only 3% of those patients received any type of mechanical support. If you look at NYHA 3 class, the pertinent finding is that in PROTECT 3, 76% of those patients were in class NYHA class 3, 60% in RESTORE EF was in class 3, and only 1/5 of patients were in class 3 for this Revive group. So we are at this exciting stage with all this evidence coming out. And right now, the ongoing trial is the randomized study, the PROTECT 4, which basically looks at complex disease patient with impaired LV ejection fraction. They divide it into, randomize it to Impella CP group versus non-Impella CP, whether be it on balloon pump support or no balloon pump support. And the hypothesis is basically they want to study by providing this hemodynamic support, whether Impella will improve more complete revascularization that will translate to a better outcome early and late at 3 years. So I'd like to end with a case. It's basically a 62-year-old gentleman who had excellent premorbid status up till 1 month ago, and he has underlying diabetes, hyperlipidemia, AFib on rivaroxaban. He presented to outside hospital for STEMI, where he had his LAD fixed, and during that procedure, it was complicated by VT storm and cardiogenic shock requiring Impella. So this was the angiogram post procedure, the LAD stent patent. You can see the swan in there with Impella CP. So the left was revascularized And you can see the retrograde filling of the distal RCA. So post ACS, echo was done showing EF of 20 to 25%. He was put on tablets and repeated echo again 3 months later, which was still 20 to 25. And this is the viability. Most of the segments were viable except for the apical inferior and apical septal walls. And he was, upon reviewing him in clinic, he was in heart failure. So with right heart cath readings showing elevated filling pressures, so he was adequately diuresed. So he was seen in clinic and consented for PCI to the RCA. So first we did a right heart, which showed basically wedge of 32, mixed venous sets of 61, preserved cardiac output. We used a single access impella approach to the right groin, put a impella CP in, and through that same sheath, we put a 7 French AL 0.75 into the RCA, and via the right radial, we got the retrograde guide 7 French EBU 3.5 to the left main and put a safety wire down the LAD. So this was the angiogram that was taken, and it basically shows a long CTO segment with a tapered proximal stump and a blunt distal stump. The length is about 40 mm with septals collateralizing the RCA, and it looks like there's a good landing zone. So our approach was to go any grade, and if it fails, then retrograde. So we basically first went in with the turnpike spiral. We tried wire escalation using Fielder XDA, Pilot, Gaia, but it seems to go subintimal. So we tried to use Mongo to knuckle in, but it kept going to the side branch despite the anchoring balloon in the guide. So at this point, we switched to the retrograde approach, and we successfully managed to serve the septals. And using IVUS guidance, we dilated the lesions and stented it. And retrograde gear was removed, and this was the final angiogram. So the right heart cath readings was okay post-procedure. The patient was weaned off the impella CP on table, and he was discharged after a few days. And on clinic visit 1 month later, he was found to be much better. He could walk to the car to appointment, from car to the appointment without any shortness of breath. He was able to spend his Christmas, and he can go up a flight of stairs twice a week. And he reports that he's feeling less lethargic, and his blood pressure improved to now baseline systolic of 120s instead of 80 to 90s. And the repeat EF that we did after 1 month revas, there was some improvement from 25 to 34%. So in conclusion, there is basically a large underserved population who are the higher risk patients who have the most to gain that can benefit from revascularization. And in those group of patients, with careful selection of these patients, we should aspire to complete revas if possible and use the state-of-the-art PCI techniques. More evidence is needed at this point, but the decision to utilize prophylactic MCS may never be wholly algorithmic. Thank you.
Thanks, Deborah. That was a very enlightening talk. Okay, any comments or questions from any of the other speakers?
So one
Okay.
just question for Deborah. Since more and more evidence maybe supports use of impella compared with IBP, so do you think IBP will still have a role as a MSS device, IBP compared with impella in the future?
Thank you for the question. I think even the balloon pump study, it didn't show, I mean, all the studies I've done, patients were too sick and the outcome was poor. But in personal experience, in those sick patients, I feel like balloon pump does have a role as well. Usually, but from my experience from fellowship, if the right heart readings are okay, patient has been optimized well, sometimes we put a balloon pump, and if the patient has severe stunning post-procedure, then we escalate to impella. So, but I think balloon pump still has a role too.
Jack, you've got your hand raised.
Yeah, thanks, Deborah. So recently, ESC had a publication Revive trial where they shows that you actually don't have to jump in and it doesn't really beat medical therapy. Can you give some guidance as to which chip patient you think you can wait and which you think you shouldn't wait and you should use the MCS-supported high-risk PCI?
I think those patients who are symptomatic, like, I mean, complex anatomy, both groups had it. I mean, in Revive, they also had complex coronary anatomy. But in terms of those patients who really in NYHA 3, 4, CCS class 3 angina without, despite on medical therapy, and has very limited physiological reserve, I think these are the groups that you might want to seriously consider mechanical support.
Deborah, I also noticed from my time in Colombia that the PA catheter is something that the operators tend to like to insert during some of these higher risk procedures. That's not something that I have seen my colleagues do, for example, in Singapore routinely. Do you recommend having the PA catheter during the procedure for chip cases? And what are the parameters that you're looking at with the PA catheter?
So basically from my experience, I know it's kind of tedious to get the swan in and then like to perform all that when you really want to get down to real business. Yeah, it is really like a religious practice in Colombia to put in the swan and do even a serial monitoring. And that is actually what they're doing right now in Protect 4 study. They're doing the right heart sub study. So basically they get the baseline right heart readings before the procedure. And then from, they put the impella and every power they go up from P2, they'll repeat the readings after 15 minutes. And then when they go up to P4, they do the right heart reading again, P6, P8. So they want to see the effect of hemodynamics that this MCS support gives. And even in the weaning phase as well, they will do all these right heart readings religiously. So basically, I think the more data will come from Protect 4 about how hemodynamic effect of the MCS. But in personal experience, I think it's really important when we do an impella to assess the preload status. And I think preload status can be done by using LVEDP, just by putting a pigtail down the LV and see how the preload status is, because we need to make sure it's well filled before the pump is started. But what the additional benefit the right heart cath gives is really, we will serially monitor with the aortic pressure during the cath, basically looking at the PA pressure, PA diastolic pressure. And then when it goes up from the baseline, we're just looking at the trend. So when it goes up during the case, we can intermittently give nitro and consider giving LASIK during the procedure. And I think the more benefit comes is when we try to decide, can we wean the impella post-procedure. With the right heart being in there, we can actually assess as you wean how the PA pressure, how the wedge is and everything, and mixed venous sets. Yeah, so I think it helps in that sense, but I do find it a bit tedious. Yeah.
Okay, thank you. Okay, I think we have, sorry. Yes, please go ahead. Yeah.
Can I ask a question, Dr. Deborah? I'm Dr. Zhang Chee from Shanghai East Hospital. Continue with previous question. In your particular case, you showed in your slides, you use the right catheter monitoring during the whole procedure. Did you see any changes after revascularization of the right coronary vessel? I mean, immediate change from the right catheter?
No, we didn't see an immediate like improvement or change, but it didn't worsen. I mean, it was okay to remove, but we don't see any immediate improvement in terms of like filling pressures or anything. Yeah.
Thank you.
Okay, I think we will move on to the next presentation, which will be from Dr. Liu Jian from Dr. Liu. Thank you.
Thank you, distinguished chairman and monitors and the audience. It's my great honor to join this session to give the lecture titled with the intravascular imaging in the calcified disease. So regarding the most audience come from the China mainland, and also we have a simultaneous interpretation at the same time. So I will give the lecture in Chinese. Thank you. 今天我来跟大家分享一下。
So today I would like to share with you the intravascular imaging in the calcified diseases. So these are the 4 contents of my agenda. So when we're talking about the coronary interventions, especially for calcified diseases, I think that's a very important one, because first is it's part of the inflammation or the repair process of the plaque rupture. So I think it's on one hand the progression of the atherosclerosis, but also the plaque itself. And I think for the severe calcification, moderate to severe, that will lead to a difficulty in the PCI procedure and might lead to a higher complication. So that's why it's very important to understand the calcified lesions. In early studies, is that if for the population aged from 45 to 84, the prevalence for the coronary calcified lesion is 50% for the Chinese, 59.2% for female, for male, and then for female is 41.9%. So a very high percentage of the patients has that. And I think if it is above 60, we found that 80% of the patients have the calcified lesions. And then what are the plaque types? So it has the plaque erosion, the TIFA, the plaque rupture, the healed rupture, and also the calcified plaque. And all these will exist in different PCI procedures. And for the first generation drug-eluting stent clinical trials, we saw that for the severe, the calcified lesions, we found that many of the patients have it concomitant with calcified lesions, and we still see a very high percentage. And then if the patient has a calcified lesion and it's very severe, and then for the PCI, it may lead to the poor expansion of the stent and also the tearing of the intima and also the poor apposition. So I think it may also the acute adverse event may also be increased. And also we can see from this trial that if the patient has severe calcified lesion, the MACE percentage or the MACE possibility will increase. And also assess that the patient has a calcified lesion that is related to the poor prognosis of the patient in the long term. For the moderate to severe calcification, this will lead to the prognosis of the PCI. This is the acuity and horizon AMI. It shows that for the unstable plaque patients, there is a high percentage of the patients they are concomitant with severe or moderate calcified lesions. So what are the methodologies we look at? For example, the intravascular imaging, IVUS, OCT, and coronary angio. And I think for the coronary angio, in the detection, localization, quantification is very weak. And then for the coronary CT, that is non-invasive, and it can look at the calcified lesions. And then for the PCIs, I think we still need IVUS and OCT more. And then for the comparison between IVUS and OCT, when we look at the quantifications, OCT has its advantage. But I think for the location and detection and the thickness, I think it's equivalent. The two methodologies are equivalent. And then for the moderate calcifications, I think it's that during the beating heart, whether they will have the distributions of a calcified, and then that is the moderate classification. For the severe calcification, so you will see the double track sign, and that is it. And then, but for the angio, you cannot see that there is a superficial calcification or the deep calcification. And then we found that this is a comparison between IVUS and OCT's detection rate of the calcified lesion. And then you found that for the IVUS and ICT and angio, that is 82.7%, 76%, and 42%. And for the IVUS, that is a very important tool to evaluate or detect the calcification. It actually emits the ultrasound waves, and some of that are reflected on the from the decibels, and then you have seen a very high resolution. So I think that's why IVUS is very good. And then VH IVUS, that is the virtual histology IVUS, and it look at the characteristics of the plaque and has the fibrosity and fibrolipid and necrotic and calcified. So the white is the calcified lesions. And for the IVUS calcified plaques, and they look at the escort shadowing, and then they have the superficial and also the deep and mix. And also for the IVUS lesions, look at the 90 degrees, 180, 270, and 360 lesions. So these are the 4 different lengths. And then for the calcified nodules, and in early days, we think that for the calcified nodule is stable. But according to the study, we found that usually calcified nodules are frequently seen in the ES, that is 2 to 7%. And the calcified nodule represents the plaque stability and also whether they have the ACS or not. And if we cannot identify the calcified nodules, then the PCI could be more difficult because the wire or the balloon is difficult to cross. And the IVUS can help us to identify the calcified features, the locations, and the length. And then we can differentiate whether that's the superficial calcific or the calcified nodules. And for the calcified nodules, I think IVUS can provide you with very detailed answers. And for the calcification score based on IVUS predicting the standard expansion rate, I think that's a very important study. That is a study enrolled with 3,862 lesions in 3,415 patients who underwent IVUS-guided PCI of a de novo. And then if it is larger than 270, we found that's a threshold. And then we randomly randomized them. And this is also the study that if the calcifier is larger than 270 degrees, and then if it is longer than 5 mm, one score, and calcium nodule 1, and if the lumen diameter is 1, and then that's the 4 scores grading scale. And then for group A and group B, it does not provide the atherectomy, and they only look at the blue. And then it can reduce the standard position expansion. And then for group A and B, and then for group C, the calcification score is much higher. And then for group D, after the treatment, it may have a better opposition. So it means that for the calcific score, it does not have a positive correlation with the standard expression. But I think for the calcification score, if it is greater than 2, it is a possible predictor for stent underexpansion. The other is the intravascular ultrasound factor associated with the atherectomy in the heavily calcified coronary arteries. And then they look at 346 lesions. They say that whether those after the atherectomy, whether patients receive a slow flow. These are the baseline data for the slow flow. The IVUS percentage is higher, and we can also see that for the atherectomy, probably it has an effect, but for the calcified nodules, we found that it is rough, and then sometimes it protrude into the vessel, and that is a very important reason leading to poor expansions of the stent. And I think IVUS can help us to understand the calcified nodules, and also for IVUS, it can help us to understand the waves, and it will look at the result of the atherectomy, and we think that this is a very important imaging to see whether that has and also we can look at whether the patient has a slow flow after the rotary grinding, and if the patient has a very noticeable calcified and also have an echo shape wave, it means that the patient has a very low possibility for slow flow. And then for the slow flow patients and the relationship between atherectomy, and when we look at the multivariate regression analysis, and they found that the IVUS sector is associated, and it is related to the reverberation, and also for the locations and angles of that. If it is larger than 300 degrees, it is also related to the slow flow. So based on these images, for example, the waves, and we can look at the slow flow percentage, and that is 2.2%, 11.9%, and 22%. So these are different. And for the OCT, we can have a better understanding of the local anatomy of the vessel and look at the inflammation. And the resolution is like 10 to 20 so that we can identify the calcific lesions and understand it better. So we think that it is very important for us to diagnose the calcified lesions. And in the OCT imaging, we can see very clearly the calcified plaque. And based on the OCT, we can look at the calcified lesions locations, length, and also the angle and thickness can be identified. So we can also look at the area of the calcified plaque. So based on that, based on OCT, we can understand the calcified lesion and how to quantify it, and what's the area of the calcified. So this is very clear, and also at the same time, OCT imaging actually classify that into different types. For example, superficial calcific and deep calcific. and calcific nodules. So all these can be identified through OCT. And for the calcified nodules and calcified disease, I think for the OCT, it can identify by 8%. And then for the OCT calcified nodule identification, there are different ones. For example, one is the eruptive protrusions and the superficial calcified sheets. So I think all of that is related to the ACS type. And also, there are new technologies called the micro OCT. It can provide a deeper rows of it. And it can also have more evidence on the plaque pressure as well. And for the spotty calcification based on the CT and comparing the IVUS and OCT, I think that is a fragility of the ACS plaque. And for the spotty calcification, it is also related to the fibrotic lipid core. And this is another paper published. They look at the thickness. If it is larger than 180, that is 1 point, and then the angle is 180, that's 1. And then for the thickness is thicker than 1.5 mm, that's also the 4 points scoring system. The higher the score is, the severe the calcification is. And we can also see that the maximum angle is 180, maximum thickness is 0.5, length 5 mm, and then the score of 4. So for those patients, if we do not treat them, usually the expansion of the stent is only 68%, and I think that is very much different from our expectation. And we think that for the PCI, especially for the severe calcification, we need to use IVUS and OCT to guide the PCS. And we think that for those, IVUS is better than looking at the calcified angle, and then for the inflammations, I think the OCT is also good. But I think for the calcified nodules and I think that is 4 mm, and the thickness is 0.57 mm, and these are the predictors of the angiographic calcification. And that was a paper published in 2017, and now we see some new point of views. And I think now we have more and more standards to consolidate IVUS and OCT. We also did some comparisons. We think that IVUS is a gold standard to evaluate the calcified lesions. It can understand the locations, the deepness, and also the length. And also for the OCT, I think it can help us to look at the areas, and it can provide a more quantitative information for the calcification. And therefore, the calcification to assess by the IVUS and OCT, what's their role and what's the impact for the pre-PCI, we can identify the calcified lesions, then we can understand whether that's a superficial calcification or deep. And then we understand whether that's a calcified nodules or not. Also, we will look at the thickness and angle to identify the feature of the calcification. And also, we will guide the procedure whether we need a rotablator or cutting balloon or the others balloons. And also we can predict how's the expansion. And then for the PCI, it's to understand the roles or the acute results of the rotablator cutting balloons, and then we will see whether we will need a further predilation to achieve a very good expansion of the stent. And then for the post-PCI, we look at that.
According to the angle of the calcification by OCT, you can see the fibrous cap and also the deep calcification. And these are the superficial calcification. The intermole is thin and a pretty large calcification. So you can have a good differentiation between different features. And here you can see the eccentric lesion. Well, the eccentric lesion make a difference in the outcome. So it looks that the eccentric lesion will not make the problem on the expansion. However, dissection may have more chance for dissection, although the expansion is not compromised. And this is the 360 or circumference calcification. If we don't do a proper management on that, for example, if we don't do the rotor, if we don't do the cutting balloon, the patient may have a lot of a problem in the future. So you can see that the average calcification thickness with calcified ring fracture was 450 micrometer. So this is a very important threshold. And if the calcium arc is more than 227 degree and the thickness is lower than 0.67 millimeter, it is easy to get ruptured. So our suggestion is that if the patient has a calcification lesion, we need to use the OCT or IVUS to evaluate that. If it is a very severe calcification, we need to do the rotor cutting, and also we can do the cutting balloon so that we can solve the problem. So if it is more than 5 millimeter, and if the angle is more than 180 and the thickness is more than 0.5, we will choose the rotor ablation or the OA or IVL. So this is very important to evaluate. And after the stenting, we can still do the IVUS or OCT to evaluate the wall apposition and expansion of the stent. So this is a very good example. And by IVUS, you can see this is the reverberation. This is a very good, prognosis for the future. And this is another indicator, which is the thickness of the calcification. It will also predict the outcome. So the conclusion is that calcification is common to see. And if you see the moderate to severe calcification, this is a poor prognosis. And IVS or OCT are helpful for us to understand the location, the characteristic, and the severity. So in the PCI for the calcified lesion, IVUS and the OCT are both very good helpers. They are handy.
Can I ask a quick one?
Yes.
Yeah. Professor Liu, can I ask if you do see a lot of calcification, would you use third generation tirupyridine, like even for elective cases, we use ticagrelor rather than clopidogrel for intervention? Does it help with the no reflow or slow flow?
Yes, I think it's a very important question. For my personal experience, if I found a very severe calcified lesion in the coronary artery, I will use IVUS OCT to identify the length, the angle, and the length of the thickness of the calcified lesion. So I will mostly use rotablation or recently use shock wave or cutting balloon to pre-treat with LEE Jin. If I found the calcified fracture, I will implant stent. The question if I will choose ticagrelor, the medicine to prevent slow flow or no reflow, I have no personal experience, but I think pre-PCI procedure preload with antiplatelet therapy is very important. Thank you.
Dr. Fan?
Thank you. 谢谢刘教授的这么仔细的这个演讲。我想问一下刘教授，对于这个钙化病变呢，他首选的这个冠状动脉内造影是什么呢？通常是有什么因素他会决定，比如用 IVUS 还是用 OCT？ 谢谢。
So when to use IVUS, when OCT? What's your indication of choosing different intravascular imaging modality? So the key is to identify the calcification lesion. I think that IVUS is equal to OCT in identifying the calcifying lesion. However, for patients with a complex situations like the angle or complexity, IVUS is better because we don't need any contrast media, and also the trackability of the catheter will be better. However, if the vessel is straight and if the contrast media has no problem, for example, non-contraindication, no limitation of the contrast media, IVUS and OCT are equal. And in terms of the quantified evaluation, OCT is better than IVUS. We don't need contrast media for IVUS. And also the resolution of IVUS is a little bit lower. However, OCT has a higher resolution. So this is your criteria, right? To use the IVUS or OCT, right? For the PCI. Is that true? Yes, correct. Thank you.
Okay, thank you very much. We have to move on to the next speaker. So I'll introduce Dr. KUA Jieli, who... Yep, we see it.
Okay, hi. So good afternoon, everyone. So thanks to KUICC and SCS for this kind invitation. So I'm Jieli, an interventional cardiologist from FAM Hospital, and the topic of my top presentation today will be physiology guided PCI for tandem lesions. So nobody likes physiology, myself included, but I do think that it is a very important part of interventional cardiology, because before we proceed to intervene on any lesions, it's important to know whether it needs to be intervened in the first place. So the famous FAM 2 trial shows that FFR guided PCI trumps optimal medical therapy alone. And from that, this has made it to the guideline recommendations, where now FFR or IFR is actually given a class 1 indication for stable IHD before we decide to proceed with PCI. We also know that if lesions are not physiologically significant, then PCI should not be performed. So what is FFR? So FFR is basically the mean ratio of your distal coronary pressure to aortic pressure at the maximal hyperemia. So we do know that there are a few problems with using FFR. So it definitely prolongs your procedure time, because you need to take time off to make the measurement and give the medicines. This will add additional costs to your patient because you need to use an additional wire. And then the drugs that are used for hyperemia, that will add additional costs as well. And it's not uncommon that the hyperemic medicines that we use do cause a lot of discomfort or side effects. So over the last few years, what has emerged is the IFR. So IFR is different in that it's a ratio of the distal pressure to the aortic pressure during this what we call wave-free period. So it's believed that in this wave-free period, the microcirculatory resistance is considered to be stable and at its lowest value. So the two trials that were done, the IFR Sweetheart as well as the Fine Flash trial, shows that the non-IFR guided revascularization is actually non-inferior to FFR guided revascularization. So what has happened is now we have a lot of different kinds of both invasive and non-invasive physiologic parameters. So the invasive one in the labs, of course, we have the traditional FFR and resting PDPA. And then we have this group which are called the NHPRs, the non-hyperemic wire-derived pressure ratios. And it really depends on which company is from. Then they come up with their different names. So Abbott will have their RFR, Philips has IFR, Boston DFR, Options DPR. So they all use the cutoff of 0.89. So what then is NHPR? So NHPR is the, they all use the ratio between the distal coronary pressure and the aortic pressure. But the difference really is the phase of the cycle where the measurement actually takes place. So it's important to note that other than IFR, they have no, the other indices have no evidence for cardiovascular outcomes. However, amongst the physiology expert, there is a consensus that the performance of all the NHPRs are considered to be equivalent. So what are advantages of NHPRs? So of course, you don't need to use any hyperemic agents. So that would lessen patient discomfort. Also shorter procedural time because your nurse doesn't need to prepare the hyperemic agents. Also, there's a perceived benefit in the assessment of serial lesions. Because coronary flow remains unstable, unlike during hyperemic conditions, it's believed that there's less crosstalk between serial lesions when you do NHPR measurements. What are some disadvantages? So smaller gradients, hence more sensitive to noise, hydrostatic pressure, and they're also more sensitive to variation of hemodynamic conditions. So for example, if you have any conditions that you think may cause hyperemia, like sepsis or even STEMI conditions, they may actually theoretically affect your baseline coronary flow. So in my lab, we use the pressure wire X from Abbott Vascular. So it has both the FFR as well as the RFR measurement. So the RFR is the lowest PDPA ratio, which is measured within the entire cardiac cycle. So unlike that of IFR, which is measured during diastole. So a minimum of 5 consecutive cycles are actually required for the measurement. Okay, so this brings me to my patient today. So basically, he's a 58-year-old gentleman who had symptoms of angina for the past few months. And his CTCA showed proximal LED severe stenosis. So he was planned for an invasive coronary angiogram in view of his symptoms. So this is the AP cranial view. So you can see a intermediate, about 60 to 70% stenosis in the proximal to mid LED. And then more distally, there's this 60% stenosis here. So same LED shot, but in the aerial cranial view, you can again appreciate the two tandem lesions. Circumflex pretty much normal. And then the RCA is also pretty much normal. So next, I went on to do my physiologic evaluation. So I first measured the RFR, which is 0.87, which is abnormal. So I went on to do a RFR pullback. So when I did the RFR pullback, the distal lesion actually contributed a 0.03 pressure gradient. So it went from 0.8 to 0.91. And then the proximal lesion went from 0.94 to 0.98. So that contributed a 0.04 gradient. I then measured the FFR, which is the lowest was 0.72. I have a habit of actually doing pullbacks for both. Particularly when I was first starting out, because that was just interesting to learn the different waveforms and learn how the two actually differ from each other. So when I did the FFR, the distal lesion actually contributed a gradient of 0.72 to 0.79, so it makes it a difference of 0.07. And the proximal lesion corresponded to what we find, or concurred with what we find on the RFR, was, in that it was a bigger gradient. So the proximal gradient contributed a gradient drop of 0.13, so 0.81 to 0.94 for the proximal lesion. So having these findings, I went on to fix the proximal LED. So I first dilated with a 2515 semi-compliant balloon, and then implanted a 2523 stent, and then went with a 275 by 15 NC balloon at high pressures. So after this, I repeated my findings. So the RFI actually turned out to be in a way normal, because it's 0.91, is above the cutoff of 0.89. I did a pullback again, and it shows the same pressure gradient drop pre-PCI, which is 0.03. And then I repeated the FFR, which is now 0.77. And when I now did the pullback, the distal pressure gradient actually increased. So now the pressure gradient actually was 10 over the distal lesion, and there was no gradient drop over the proximal lesion now. So with these findings, I went on to now intervene on the distal lesion. So I pre-dilated with a 22515 NC balloon. And what I did here was I decided to use my physiologic indices to see if my balloon dilatation was adequate. So my RFR finding post-balloon dilatation only improved it to 0.92. and the FFR was now actually 0.83. But when I did the pullback, I didn't find any pressure gradient drop at all. So I thought this was a good time to use a drop-coated balloon. So I used a 225 by 20 drop-coated balloon, inflated for about 45 seconds. And then this is the final picture. So you can see that the stent is well expanded, very minimal dissection in the distal LED, but no flow limiting. And actually you can probably appreciate that actually the whole LED is probably, there's a little bit of disease here and there with the proximal or ostial segment actually even about the same size as your mid to distal segment. So this gentleman actually completed his 1-year follow-up and remains asymptomatic and physically active. So these are just some small studies that I thought I would share, showing how you can actually use physiology to decide if DCB is warranted. So this is a small study, 6 patients. Basically what they did was if your FFR was more than 0.85, then they will use a DCB. If it's less than 0.85, then they will implant a stent. And actually show that at 9 months, the late lumen loss with DCB was actually less. This is a bigger study, 200 patients now. So in this one, they use a different cutoff of 0.75. But if your FFR is more than 0.75, the interventionists could either use a DCB or a stent. However, if the FFR is less than 0.75, then they'll definitely implant stent. So again, reflects what we found in the previous study. The late lumen loss was actually lower in the DCB group, and there was actually no difference in cardiac events. So this has made it to the consensus, the DCB consensus document, the statement release. So where they actually advise on how or which scenarios DCB will actually be appropriate. So in this consensus document, they actually use a FFR value of 0.8. If you have that, then it is reasonable to actually consider using a drop-coated balloon. So just some pointers in terms of FFR and tendon lesions. So to do that, you definitely need to use a long-acting hyperemic agents. I think quite a few of us actually use intracoronary adenosine, so we know that that is definitely too short-acting. So in my center, we use intracoronary papaverine. That lasts for about 45 seconds. In many centers, they do have IV adenosine. That is definitely the gold standard. It's important to always do a pullback to define your pressure gradient. And in general, 10 millimeters mercury drop is actually considered a significant pressure gradient, meaning that likely to benefit from PCI. We also should remember that the distal severe lesion is more likely to mask the proximal one rather than vice versa. So for example, if you have a proximal LED lesion with an FFR of 0.65, and then if you have a distal lesion that is significant, the distal lesion is going to reduce the flow across the proximal lesion. So what happens is your pressure gradient is going to be less. So it might be 0.79 when you measure. Yeah, and then after you fix it, it will become 0.6 something. So when you do a pullback, always fix the one that you find the more significant gradient first. And always important to repeat your FFR post-PCI to look for any residual gradients, because this is important to know if you have left anything behind and whether any lesions needs to be further treated. Another thing to note is that the optimal PCI, post-PCI value for LED is generally lower than that of the circumflex and RCA, just because of the myocardium sectended. So it's not uncommon that when we do a LED physiologic guided PCI, that at the end of the case, you find that your FFR value is actually not as satisfactory as when you do a circumflex or RCA. So some things to note for NPHR and tendon lesions. So amongst the various companies, only the IFR and RFR have a pullback analysis. And I think the IFR, I don't have the IFR machine, but it does have a CoRESH system, and where on the angiogram, they actually show you the each dot represents 0.01 gradient, and how theoretically it's supposed to help you in terms of if you fix that certain lesion, it will tell you exactly how much it's supposed to improve by. So NPHR supposedly less crosstalk between serial lesions. I think a good advantage in our NPHR is also that you can repeat your pullback if you're unsure. So if you have if you're just starting out and you do a pullback, sometimes you may actually the technician may miss putting a bookmark, for example, or you may pull back too fast. Because you don't need to give any additional medicines, it's always okay to just put it back down and just repeat it as many times as you want to make sure that you know which lesion is more significant. It's also important to repeat your pullback after your PCI. You always should look for any residual gradients, especially in suboptimal results. And in the defined PCI, actually what they found was that in more than 60% of their suboptimal post-PCI results, actually they still found focal residual disease located outside the stent. So despite what the KUA system does promise, you should know that you can still miss focal lesions even by performing the co-registration pullback. So one thing to note also is post-PCI, I do find that the MPHR value sometimes does not change that much, and it's actually due to this phenomenon called the post-occlusion reactive hyperemia. You should allow ample time to pass, because all this ballooning actually induces a bit of hyperemia, so that actually affects your MPHR values. So you should allow some ample time before you repeat your post-PCI MPHR values. So some learning points, I think both FFR and MPHRs can actually be useful, and of course both have their own problems during the decision-making process for tandem lesions. It is very important that when we do a pullback, you should record the values before and after the lesions, because only in this way then you can know which stenosis will be amenable to PCI. Always remember to repeat the measurements after your PCI. And I think FFR post balloon angioplasty may actually be a useful tool to assess the efficacy of your DCB approach. Thank you.
Thanks very much, Jieli. That was very illustrative with your case. I want to ask you a question about, in particular, right? In particular to tandem lesions, where you have already treated one of the two lesions and you reassess the FFR or IFR, RFR. What is the value that you would accept in that case to say that you've done enough?
Yeah, so I think it's really looking at the gradients. So I think it takes a bit of experience, because initially I think when I first started out, sometimes a little small gradient, you think it's a gradient, then you go on to fix it. But actually you kind of realize that for anything to really make a change, you really need to have a big enough jump. So when you do the pullback, you should find a big enough jump. And as I mentioned earlier, I mean, some do recommend a pressure gradient drop of 10 millimeters mercury. So I think that can be a good number to go by.
So you're saying you don't look at the value of FFR or IFR, or rather you look at the pressure drop as you pull back the wire.
Oh, you mean post-PCI, what value I'll be happy with?
Yeah, let's say you have tandem lesions and you've fixed one, and then you want to decide whether or not to fix the other. What value would you accept?
Yeah, and then actually I will still go by that. If I don't find any gradients, I mean, we do know that your FFR and RFR post-PCI, the higher the better, but you know that in certain cases where you have diffuse disease, you're never going to reach a normal value or a high enough value. So if I don't find any jump, I'll just stop.
Okay. Does anybody else have any questions?
Jieli, thanks very much for the detailed lecture. I have a question regarding the use of IFR and FFR. As we know that IFR has been proven to be non-inferior to FFR, as seen by Sweetheart and Defined Flare. I just want to ask, do you think IFR can completely replace FFR in the use of physiological assessment of coronary artery lesions? The other question that I have in mind is, some of us actually do both IFR and FFR as well. Sometimes the values are concordant with each other. Sometimes they are discordant. And what's your take on that? I mean, what happens if, for example, the IFR shows that the lesion is significant, whereas the FFR shows that it's non-significant, for example. How do you deal with this kind of scenario? Thank you.
So I think the first question is whether you replace. I think the answer is no. It depends on which center and you're in and your comfort level. So we know that a lot of people are very adverse to doing FFR because of the use of medicines and the longer time taken. So a lot of people prefer something more convenient. And at the end of the day, my own take is that there's FFR, there's IFR. There's also stress nuclear, there's also stress echo. So sometimes patients come on the table, you don't perform any physiologic finding. Patient has angina, you just go on to fix the LED because it corresponds to your stress echo finding. So if you do IFR and patient has real angina, choose to believe it. If a patient has atypical symptoms, even if the FFR is normal, then you should. You know that after you fix it, the patient is still going to come back to your clinic and tell you he has poking pain. So I don't think it's a matter of replacement, but I think it's a use of different tools for us, pretty much like IVUS and OCD. Certain scenarios may be better, depends on operator comfort level. So, and then with respect to discordance, I think that itself is a huge topic. We do know that IFR, there is some more correlation with diffuse disease, a bit more correlation with microvascular dysfunction. FFR tends to maybe be more abnormal in focal lesions, LED, more proximal lesions. Yeah, so there are a few of these that may explain discordance. But I think the general rule of thumb is that if both are normal, then definitely the long-term prognosis is good. If either one is abnormal and the other one is normal, is still not so bad. If both is abnormal, it's definitely bad. And I do find that for the ones that are kind of discordant, they're usually around the borderline range. You very seldom find an FFR of 0.61 and then the RFR is like 0.92. So for me, a lot of these patients with borderline measurements is actually at the end of the day, you might not even need to, whether you want to treat them, I think it's also a discussion with the patient. You have something that's borderline. Do you want to try medicine first? So, I mean, that's how I would usually go around this.
Thanks very much for the insightful answer.
Okay. Deborah, you had your hand up for a while. I don't know if you still want to ask your question.
I just want to ask, like, you use intracoronary papaverine for tandem lesions. What's the dosage that you use? Is it different for LAD and RCA? And do you get like patient having BT on table? Is that frequent?
Yeah, so the dose that I use is 1510. Some operators in my hospital use 2015, meaning that the higher dose for the left circulation. But I think you can go as low to 812 also if you look at certain studies. So I mean, it depends on the individual person. QT is actually not uncommon. There are certain, so usually there's a certain patient profile that you know that they are more likely to get VT. So women, I know that women are more prone to getting it. Like patients with a lot of PVCs, you know that once you prolong the QT, it's very high chance that they'll get it. Patients with low EF or electrolyte abnormalities also more common. So I do try to inject it a bit slower. I actually do it very, very slow. I do find that helps because there are certain situations where you inject slow and then sometimes the saline flush, you forget, and you just flush it quite fast and then she just goes into VT. So for me, I always ask the nurses to actually leave the defeat pads on before we do it. Having said that, I actually had a case with intracoronary adenosine and I actually had VT some weeks back. So that was a bit unusual. Yeah, so yeah.
Okay. Thanks, everyone. We must move on. And let me introduce.
Thanks for the chairman. I have to say sorry that I prepare all my slides in Chinese, but I think you all can understand Mandarin. But for the audience, I have to say sorry. 非常感谢那个会务组安排这个。
First of all, I would like to thank the organizing committee for the opportunity, and it is a great pleasure for me to see many of the great experts here, and this is the topic for me, PCI, for the chronic kidney disease patients. And this is a patient that impressed me a lot. So I would like to start with this case. This is a 63 male patient admitted for heart failure. And when we are doing the angio for those patients, we usually need to see that these are the diffuse multivessel lesions and severe calcification. And I think this was very commonly seen. And actually, there are many common risk factors for cardiovascular diseases and also the chronic kidney diseases. So I think sometimes we talk to the nephrologist and we say that for the chronic disease, kidney disease patients, many of them concomitant with the cardiovascular diseases, that is also very high. And we also see that for the CKD patients, usually they have a very high onset or high incidence of cardiovascular diseases patients, no matter for the heart failure or other cardiovascular diseases. So and then when we look at the PCI rate for the CKD patients, and we found that 1/4 to 1/3 of the patients that receive the PCI actually have the CKD. And then we found that for those the PCI patients, many of them has the CKD. This is also from that for the eGFR and ACR and all-cause mortality and also the cardiovascular death are all related. So, and I think that is also very related. And I think for the PCI patients, and I think when we look at the CKD, that is also related to their long-term survival rate. And we can see that the survival rate is also related to their CKD conditions. When we look at the PCI, we can see that when we look at the chip, for the chip, I think we can treat all the lesions like the CTO and the SVGs, and we always have a way to treat those lesions. But I think whether that's enough, whether we should treat those patients is what we need to look at. It's not whether we can treat or not. I think that's a very different question, because we think that yes, we can definitely, but whether we need to treat those patients every time they visit us or not. And then when we look at that, CKD is an independent predator for the risk of the revascularization, and we can see it from here that for those patients concomitant with CKD, I think that those CKD is another independent factor for the mortality prediction. So for the CKD, it is a independent predictor for the bleeding, and we also see that this is commonly looked at. So for the CKD patients, and usually they have a high risk. And for those patients, what are the treatment we need actually is a balance of the decision. I think for the CKD patients, there are limited evidence of treating those patients for the coronary artery diseases, but I think it's always a cabbage versus PCI. And for the CKD patients, from the subgroup analysis, we think that this is the syntax subgroup analysis for the patients. And then for the CKD patients, whether no matter what type of revascularization they reach, and they found that usually the prognosis are the same with non-CKD patients. And then for the PCI group, that is higher than the CABG group in terms of all-cause modality and revascularization. There are also some meta-analysis says that for the PCI treatment in early stage, they can improve the survival of the patients and has less peri-procedure complications. But for the long-term survival, CABG has more benefit for those patients. So for those CKD patients, what to choose, whether it's a CABG or PCI, is that we need to look at both the immediate outcome and also the long term. I believe that you're all very familiar with the ischemia CKD study. I think these are the trials that look at the revascularization versus the medication treatment for the CKD patients with coronary diseases. And then they also look at invasive strategy and conventional strategy. So these are only look at the CKD populations. Then we look at this result. We found that for the death and the CV death, cardiovascular deaths, actually the conventional strategy and invasive strategy, it has no significant difference. And for the death primary endpoint, I think for the convention and invasive, that's the same. And then for the CV deaths, we also see that this is the 4-year follow-up, that the conventional strategy group and invasive strategy group are very similar. There's no statistical difference. And then when we look at the ischemia CKD extent, they look at those patients then follow up for 5 years. Then we look at all-cause modality. And then for the conservative ones, that is 37.4%, invasive is 40.6%. For those populations, I think usually the prognosis of those patients are very poor, because at least that we know that this is all-cause mortality, and that is actually very high. And for the invasive group and also the conservative group, and we can look at it, there is actually no not much difference, and the result for the patient long-term prognosis is very similar. And for the cardiovascular death, and that's also very similar to each other. There is no statistical significance, a difference. And then when we look at this study, we could have some information. We think that for those patients, probably for conservative ones, it's very similar to the invasive one. And that one, we still need to treat those patients. And then for the CKD patients with the non-STEMI, and we can see that this is could be very different results. For the CKD concomitant with a non-STEMI, we found that for the in-hospital mortality, 6 months and 6-month mortality, and preferred the invasive strategy rather than the conservative strategy. So from that study and also the meta-analysis, need to look at different subgroups of the CKD, because for the CKD patients, if we have seen those patients have a non-STEMI, we probably prefer the invasive strategy. The other is the safety analysis, because for those patients, if we do not provide invasive strategies, probably they will still see that. And but that I think the two groups does not have many different strategies. I think for the major bleeding and also for the stroke and AKI require analysis. And though from the major bleeding, and we probably think that the conservative will be better, but actually, we found that the incidence of that is very low. So for the CKD concomitant with non-STEMI, usually we will treat those patients. And for the contrast-induced AKI, and I think for those patients, this is what we need to look at when we treat the CKD patients.
So you can see that the this is the rate of the acute renal impairment after CTO PCI. You can see that we can have a pretty good strategy to mitigate the risk. However, there is one set of data we're going to share with you. You can see that for the patient with baseline renal dysfunction, and then the patient had a CTO, and patient had the PCI for CTO, and once the patient has a renal impairment, the mortality will be higher. So for the CKD cases, if we're going to do the PCI for CKD cases, these are the key points. The firstly, I will have 3 stages to focus on. The first is preoperative stage. We will screen for the drugs which may impair the renal function, and we will evaluate the volume. We will evaluate the perfusion and the existence of hypovolemia. If the volume is not sufficient, the renal function will be even worse. And also for patients with renal dysfunction, we will give patients the hydration before the contrast media. The hydration is a strategy to prevent some complications. So here you can see this is the protocol for hydration. And during the angio and PCI, we should calculate the dosage. So it should be less than 3.7 times EGFR. And also, we need to ask the nephrologist to have the consultation to have a preventive dialysis. So this is a very important measure, to plan for the dialysis, and we need to plan for the possible post-operative dialysis as well. So these are the high risk factors for AKI. For patients with a CKD, if they are going to receive PCI, we can take these kind of actions. So try to reduce the dosage of the contrast media as much as we can. And I'd like to say that the role of the isotension contrast media is not confirmed. But anyway, we try to reduce the dosage of contrast media as much as we can. So in terms of the techniques, we can do the super selection for angiogram, and then we can evaluate the vessels. And also we can stage the treatment instead of doing everything in one stage. So these are the actions to reduce the dosage of contrast media. Try to save the contrast media. IVERS is a very good evaluation modality because it's contrast media free, so that we can achieve the ultra low contrast angiography. The most important thing is to control the dosage of the contrast media. You need to have a good calculation, and of course you need to have a good exposure. And on the other side, you should minimize the dosage of the contrast media. So these are the relevant clinical trials on IVERS. So this is the IVERS XPL. It looks that the IVERS guided PCI will have a better clinical outcome. This is the mean follow-up. So why I talked a lot about IVERS? For the CKD cases, if we're going to reduce the dosage of the contrast media, we can rely on this kind of IVERS examination to reduce the need for contrast media. And after the operation, we need to have a continuous hydration. For the patient with severe heart failure, we need to monitor the hemodynamics, and we need to monitor the urine, and we will recheck the renal function 2 to 3 days after the operation. And if necessary, we should give patient a CRRT. And these are the risk factors for CKD, CVD. So you can see that these are the risk factors control. You can see a very good control of the lifestyles. You can see that this is something we need to pay attention to. And here you can see this is on the case. You can see this is on the PCI case refused by the cardiac surgeons. So we staged the treatment for the 3 vessels. So this is the change of the heart and kidney function. You can see that the creatinine is maintained at 200 and keeps stable. So this is 11 months after the last PCI, and the patient had a heart failure, and then we check the angiogram again. So the patient is waiting for cardiac surgery. So for this case, the procedure is successful. We have a good planning, we have a good preparation, we have a total revascularization, we prevented CI, AKI, and we have the IVUS guidance and how to improve the survival and how to reduce the long-term adverse events. We still need to consider a lot of things for this case. Thank you. This is all I'd like to share with you.
Okay, 谢谢 Zhang 老师. That was wonderful. I think we have maybe time for just one comment or question. Dr. Pham, I think you might have something.
Thanks, Dr. Chin. 张教授，谢谢你这个很仔细的这个演讲。我有一个问题，你刚才有提起这个 ultimate trial， 之前它是显示了 IVUS 引导的这个 PCI 胜于血管造影引导的这个 PCI。临床结果呢，的 IVUS 的引导的 PCI 是胜于这个血管造影的引导。我想问张教授的这个问题是，你认为所有这个慢性肾功能患者疾病呢，都是应该使用 IVUS 来做 PCI 吗？谢谢。
For patients with a chronic kidney disorder, chronic kidney dysfunction, do you always use IVUS for guidance? So for patients with some calcification or with some chronic kidney dysfunction, I will rely on the imaging technology to evaluate the heart, evaluate the stent, and then to reduce the long-term complications. So I'm very active in using the intravascular imaging to give me immediate feedback from the procedure. So I have a low threshold in using the technologies.
I think we should. Yeah. Oh, Deborah, you have a question?
Yeah, I just want to ask to Dr. Chin. I mean, does he normally split the procedure into half, like diagnostic and then wait? If he does wait to bring the patient back for PCI, how long does he wait, to minimize the contrast load?
Yes, usually we will separate the procedure because for patients with baseline CKD, they always have complex coronary lesions. And one of the reasons I prefer the patient is I need to discuss with my surgeon colleagues to evaluate the possibility of CABG and also discuss with the family, with the patient. So it's a very good excuse or reason why I can refer my patient for the staged PCI if they decided finally to receive PCI.
Yeah, I would agree. If it's not an emergency case, if the PCI can wait a little bit, it is probably better for the kidneys anyway to stage the procedure. Okay, I think we have come to the end of the session. It is already 3:30 in the afternoon. I would like to thank all the speakers for their wonderful presentations and for taking part in the discussion. I would like to thank QICC again for inviting the Singapore Cardiac Society to participate in this session this afternoon. I hope it has been educational for everyone, certainly very educational for me. Okay, thank you very much. 谢谢大家.
Thank you.
Thanks,
Bye-bye.
everyone.
Bye.
Thank you.
Okay, 谢谢张老师. That was wonderful. I think we have maybe time for just one comment or question. Dr. Pham, I think you might have something.
Thanks, Dr. Chin. 张教授，谢谢你这个很仔细的这个演讲。我有一个问题，你刚才有提起这个 ultimate trial，之前它是显示了 IVUS 引导的这个 PCI 胜于血管造影引导的这个 PCI。临床结果呢，的 IVUS 的引导的 PCI 是胜于这个血管造影的引导。我想问张教授的这个问题是，你认为所有这个慢性肾功能患者疾病呢，都是应该使用 IVUS 来做 PCI 吗？谢谢。
For patients with a chronic kidney disorder, chronic kidney dysfunction, do you always use IVUS for guidance? So for patients with some calcification or with some chronic kidney dysfunction, I will rely on the imaging technology to evaluate the heart, evaluate the stent, and then to reduce the long-term complications. So I'm very active in using the intravascular imaging to give me immediate feedback from the procedure. So I have a low threshold in using the technologies.
I think we should. Yeah. Oh, Deborah, you have a question?
Yeah, I just want to ask to Dr. Chin. I mean, does he normally split the procedure into half, like diagnostic and then wait? If he does wait to bring the patient back for PCI, how long does he wait? To minimize the contrast load.
Yes, usually we will separate the procedure because for patients with baseline CKD, they always have complex coronary lesions. And then one of the reason I prefer the patient is I need to discuss with my surgeon colleagues to evaluate the possibility of CABG and also discuss with the family, with the patients. So it's a very good excuse or reason why I can defer my patient for the staged PCI if they decided finally to receive PCI.
Yeah, I would agree. If it's not an emergency case, if the PCI can wait a little bit, it is probably better for the kidneys anyway to stage the procedure. Okay, I think we have come to the end of the session. It is already 3:30 in the afternoon. I would like to thank all the speakers for their wonderful presentations and for taking part in the discussion. I would like to thank QICC again for inviting the Singapore Cardiac Society to participate in this session this afternoon. I hope it has been educational for everyone, certainly very educational for me. Okay, thank you very much. 谢谢大家.
Thank you.
Thanks,
Bye-bye.
everyone.
Bye.
Thank you.